Welcome back to the deep dive. Our mission, as always, is to sift through complex clinical sources, pull out those crucial diagnostic nuggets, and get them to you, the learner, in a way that sticks.
Absolutely. And today we're diving into really a fascinating area, ENT and oral maxillofacial conditions.
It really is. And the theme that jumped out from the sources is this idea of misdirection, right? Pain showing up in one spot, like the ear, but actually starting somewhere else entirely.
Exactly.
Oh,
It's all about those clinical clues, sometimes subtle ones, that help you figure out what's really going on. And crucially, differentiating between something that's, just annoying versus a condition that's genuinely dangerous.
okay, so let's kick off with maybe the most classic example of that misdirection. The patient comes in complaining of really bad ear painalgia. We do the exam, look in the ear, external canals clear, the eardrum looks totally fine, moves well, everything seems normal. Now what?
Right. And that very finding, or maybe the lack of a finding inside the ear, that's your first big clue. It tells you, okay, stop focusing just on the ear.
You've got to broaden the search.
You have to. Think about the neighborhood. What structures nearby share nerve pathways? Because that's often where the problem lies. It's the nervous system basically sending a confusing signal.
Okay, let's dig into that. So if the ear looks fine but hurts, number one on the list has to be temporomandibular joint disorder, TMD. Our sources talk about it as basically pain or dysfunction involving the jaw joint or the chewing muscles.
That's the one. It's a huge mimic for ear pain.
So mechanically, how does a problem in the jaw joint make the ear hurt?
Well, it's partly just anatomy. The TMJ sits right there, right next to the ear canal.
Mm-hmm.
But the really key thing is the shared wiring, the nerves.
Ah, the innervation.
Exactly. The auriculotemporal nerve, which is a branch of the big trigeminal nerve, specifically the V3 part, it supplies sensation to both the TMJ and parts of the ear, like the external canal.
So they share a nerve line, basically.
Pretty much. So if you get inflammation or muscle spasm around the joint, the brain gets these pain signals, and it can easily misinterpret them as coming from the ear, because that's a common place to feel pain in that area. It's classic referred pain.
Right, like a crossed wire. So what's actually causing that inflammation or spasm in the first place? The sources seem to really hammer on stress and grinding.
Yeah, overwhelmingly, TMD symptoms come from the muscles, what we call myofascial pain. And the biggest driver for that is often bruxism, that unconscious grinding or clenching of teeth, especially at night.
Which is often stress-related, right?
Very often. Anxiety, stress, these are major risk factors. All that grinding puts, tremendous repetitive force on the jaw muscles and the joint itself.
Leads to muscle fatigue, spasm.
Exactly. Lactic acid builds up, the muscles get tight and sore, and you end up with this chronic pain cycle. That's why asking about stress or anxiety is actually a really important part of the history for jaw pain.
Makes total sense.
Yeah.
So, okay, you suspect TMD. The ear exam is normal. What else are you looking for? Is there like a classic triad?
There really is. The sources consistently point to these three things. First, unilateral facial pain, often right in front of the ear, preauricular pain, and it gets noticeably worse with using the jaw.
Like chewing, talking.
Chewing, yawning, even talking a lot, yeah. Second, the ear pain itself, the otalgia, but with that completely normal ear exam we talked about.
Got it.
And third, you look for the footprints of the cause, usually signs of bruxism. So check the teeth. Are they worn down, flattened? Any fractures? Sometimes you can even see ridges or scalloping on the sides of the tongue from clenching.
Okay. So pain with chewing, normal ear, worn teeth. What about the physical exam beyond just looking? Any maneuvers?
Definitely. You want to palpate. Gently press over the TMJ itself, just in front of the tragus of the ear while the patient slowly opens and closes. Tenderness there is a big clue. And then feel the muscles themselves. The big masseter muscle on the side of the jaw, the temporalis muscle up on the temple. Are they tender? Do you feel tight bands, trigger points? That suggests muscle spasm.
Yep.
You might also notice the jaw isn't working quite right. Maybe some clicking or popping sounds, crepitus, when they move it. Or you can even measure, see if they can't open their mouth as wide as they should, reduced interincisal opening.
All right, so we've got the triad, maybe some tenderness or clicking. How do we manage this? The sources emphasize conservative care, right? Not jumping to surgery.
Oh, absolutely. The first line is almost always conservative. Education is key, explaining what's going on. Then simple stuff. Recommend a soft diet for a few weeks. Let those muscles rest.
So no steak, no chewing gum.
Definitely no gum. Avoid anything really hard or chewy. Warm compresses can help relax the muscles too. And then if you strongly suspect bruxism, The nighttime bite guard or occlusal splint is critical.
Does that actually stop at the grinding?
Not really, but it changes how the forces are distributed. It protects the teeth from wearing down further and can help the muscles relax a bit. And for those really acute flare-ups, when the spasm is bad, a short course of NSAIDs can help with pain and inflammation. And sometimes, a muscle relaxant like cyclobenzaprine for a few days can break that acute spasm cycle while the other measures kick in.
Okay, that makes sense. Focus on function and rest. But jaw pain and swelling isn't always TMD. It could be coming from the salivary glands, right? Like salivary stones, silothiasis.
Exactly, and this is a great comparison because it highlights a totally different trigger for the pain. With PMD, pain gets worse with movement. With silothiasis, it gets worse because of saliva flow.
Okay, explain that. What is silothiasis exactly?
It's basically a stone, like a tiny kidney stone, forming inside the duct of a salivary gland. It blocks the flow of saliva.
Any gland. Or is one more common?
It can happen in any, but the submandibular gland is the most common site by far.
Why there?
Couple of reasons. Its duct, Wharton's duct, is kind of long. It travels uphill against gravity to empty into the floor of the mouth. Plus, the saliva from the submandibular gland is thicker, more mucousy. Both those things promote stasis, sluggish flow, which makes it easier for minerals to precipitate out and form a stone.
Okay, stasis leads to stones. So how does that blockage cause the symptoms that help us tell it apart from TMD?
It all comes down to when the pain happens. The absolute key differentiator is recurrent jaw pain and swelling that gets dramatically worse when eating or even just thinking about food.
Yeah, the salivary reflex.
Precisely. When you eat or anticipate eating, your brain tells the glands produce saliva. So you get this rush of saliva production. But if the duct is blocked by a stone, that saliva backs up, causing intense pressure, pain, and visible swelling of the gland itself. It's often called salivary colic.
And then when the stimulation stops?
The pressure slowly goes down, and the pain and swelling subside until the next meal. That specific pattern, worse with meals, better between meals, is the classic sign.
That's a really clear distinction. TMD, pain with movement, silothiasis, pain with salivary stimulation. What happens if that stone just stays blocked?
Well, chronic blockage leads to stasis, and static saliva is a great place for bacteria from the mouth to grow. So you can get a secondary infection of the gland itself that's called silodenitis.
So then you'd see signs of infection.
Right. Fever, redness over the gland, increased tenderness, maybe even pus draining from the duct opening in the mouth. Initial management is usually trying to encourage the stone to pass lots of hydration, warm compresses, massaging the gland towards the duct opening. If there's infection, you need antibiotics. But if stones keep recurring,
Then you need to get the stone out somehow.
yeah, then you might need procedures to remove the stone or sometimes even the gland itself if it's chronically damaged.
Okay, before we leave jaw pain, let's quickly differentiate from a couple other things. Trigeminal neuralgia, how does that look different?
Oh, completely different beast. Trigeminal neuralgia isn't about swelling or inflammation in the same way. It's nerve pain. Patients describe it as sudden, excruciating, like an electric shock.
Stabbing pain.
Exactly. Often triggered by something really light, like touching a specific spot on the face, brushing teeth, even a cool breeze. There's no swelling, no fever, no link to chewing effort or meals like TMD or stones. It's purely neurological.
Got it. And one more, especially important in older folks, giant cell arteritis.
Right, GCA. This is a systemic inflammation of arteries, often the temporal artery. Now, it can cause jaw pain, specifically something called jaw claudication.
Like leg claudication, but in the jaw.
Kind of. Pain in the jaw muscles that comes on specifically with chewing and gets better when they stop chewing. So there's some overlap with TMD there, the chewing trigger.
But how do you tell them apart?
GCA comes with a whole constellation of other signs, usually patients over 50. They often have headaches, scalp tenderness, maybe fatigue, muscle aches. And the really scary part is the risk of sudden permanent blindness if it's not treated.
So it's a systemic illness, not just localized jaw pain.
Exactly. It's a medical emergency. Needs high-dose steroids immediately. So yeah, jaw pain with chewing could be TMD, could be GCA. You need that full history and the associated symptoms to sort it out.
Okay, let's shift focus back inside the ear now, but moving away from acute pain to more chronic, sort of insidious problems. And one that really stands out from the sources is cholesteatoma. Sounds serious.
It is serious, even though it's not technically cancer. A cholesteatoma is basically skin growing in the wrong place, specifically in the middle ear space or the mastoid bone behind the ear.
Skin? How does skin get in there?
It usually starts with long-term problems with the eustachian tube, that little tube connecting the middle ear to the back of the throat. If it doesn't work properly, You get chronic negative pressure in the middle ear.
Like a vacuum effect.
Sort of, yeah. And that negative pressure can suck the eardrum inwards, especially the more flexible parts of it, creating a little pocket or pouch or retraction pocket. Now, the skin on the outside of the eardrum normally sheds and migrates outwards, cleaning itself. But if skin cells get trapped inside that retraction pocket, they can't get out. They just keep shedding layer upon layer, accumulating keratin debris. And that trapped ball of skin and debris is the cholesteatoma.
And it just keeps growing.
It keeps expanding, yeah. It acts like a benign tumor in that sense. It grows and destroys surrounding structures.
So what are the typical symptoms? You said insidious, so maybe not dramatic pain.
Often not much pain, especially early on. The classic presentation is chronic, painless ear discharge otorrhea, maybe for months. Often they've had multiple rounds of antibiotic drops or pills that just didn't clear it up.
Resistant discharge.
Right. And usually there's also a gradual conductive hearing loss on that side because the cholesteatoma can damage the little hearing bones. The hearing loss or the persistent discharge is often what finally brings them in.
And when you look in the ear, what's the visual clue?
You might see that retraction pocket we talked about. But the key thing to look for, often tucked away in that pocket, maybe in the upper part of the eardrum, is a white, pearly-looking mass, or sometimes just visible white keratin flakes or debris. That pearly appearance is very suggestive.
Okay, so chronic discharge, hearing loss, maybe a pearly mass. Why is this considered something that needs urgent surgical attention if it's not cancer?
Because it's locally destructive.
Right.
That trapped skin and keratin debris triggers chronic inflammation, and critically, the cholesteatoma releases olytic enzymes that literally dissolve bone.
Wow. So it eats away at the structures around it.
Exactly. It can erode the ossicles, the little hearing bones, malleus and cuccus stapes, making the hearing loss much worse. If it keeps growing, it could erode into the facial nerve canal, which runs right through the middle ear and mastoid.
Causing facial paralysis.
Yes, facial nerve palsy. It can erode into the inner ear, damaging the balance canals and causing severe vertigo. Or it can even erode upwards through the thin bones separating the ear from the brain.
Leading to intracranial complications.
Meningitis, brain abscess, really serious stuff. So even though it's benign tissue, its behavior is destructive, which is why surgery to completely remove it is essential to prevent these complications.
Okay, that's a specific and dangerous cause of hearing loss. Let's broaden out now to the most common type overall, especially as people get older, presbycusis.
Right. Age-related hearing loss. This is the classic example of sensorineural hearing loss, or SNHL, meaning the problem is in the inner ear, the cochlea, or the auditory nerve itself, not the outer or middle ear.
And it's usually gradual, right? Both ears.
Typically, yes. Progressive, usually symmetric, affecting both ears fairly equally. It's really just a consequence of wear and tear over time. The main issue is the gradual loss of the sensory hair cells within the cochlea, the ones that actually convert sound vibrations into nerve signals, and also some degeneration of the nerve fibers themselves, the auditory nerve, CN88.
You often hear people say, I can hear people talking, I just can't understand what they're saying. Why that specific difficulty?
That's because presbycusis typically affects the high-frequency sounds first and most severely.
Like consonants.
Exactly.
Yeah.
Sounds like sapphilate, the sounds that give speech its clarity. When you lose those high frequencies, speech starts to sound muffled, indistinct. Vowels, which are lower frequency, might come through okay, but the consonants get lost.
And that's why background noise makes it so much worse.
Precisely. Background noise is often low-frequency dominant, so it masks the already weakened high-frequency speech sounds, making it incredibly difficult to follow conversations in noisy places like restaurants or parties. People also often mention having more trouble understanding women's or children's voices, which tend to be higher pitched.
Okay, so that's age-related SNHL. Now, another type of SNHL the sources highlight is iatrogenic caused by medications, ototoxicity, and they single out one common class of drugs.
Yes, this is really important for safety.
Right.
While several drugs can be ototoxic, certain antibiotics like aminoglycosides, some chemotherapy agents, a very common culprit, especially in hospitals, are the loop diuretics.
Like furosemide, Lasix.
Exactly. High doses, especially when given intravenously, can damage the inner ear. The main target seems to be a structure called the stria vascularis in the cochlea.
What does that do?
It's like the battery for the cochlea. It maintains the specific chemical environment, the electrical potential that the hair cells need to function. Damage that, and the hair cells stop working properly.
And is there anything that makes that risk even higher?
Yes, absolutely. The big one is renal impairment, kidney problems.
Why?
because the kidneys are responsible for clearing furosemide from the body. If the kidneys aren't working well, the drug hangs around longer at higher concentrations, increasing the toxic effect on the ear. So the combination of high-dose 5E furosemide plus kidney failure is particularly dangerous for hearing.
So a patient getting aggressive IV diuretics for heart failure or edema who also has bad kidneys and then suddenly develops hearing loss or tinnitus.
You have to suspect otoxicity. Red flag. Need to reevaluate the dose, maybe switch agents if possible.
Okay, so we have presbycusis, SNHL, age, ototoxicity, SNHL, drugs. How does this contrast with something like otosclerosis? That's different, right?
Completely different. Otosclerosis is primarily a conductive hearing loss, meaning the problem is in the middle ear, blocking sound from getting to the inner ear.
What's the mechanism there?
It's abnormal bone growth.
Hmm?
Specifically, spongy bone grows around the stapes and one of the little hearing bones, fixing its footplate in place so it can't vibrate properly in the oval window.
So sound just doesn't get transmitted effectively.
Right, and it typically affects younger adults, often has a genetic component. And here's a fascinating clinical pearl that helps differentiate it.
Yeah.
Patients with otosclerosis sometimes report they hear better in noisy environments. It's called the paracusis of Willis.
Better in noise. That seems backwards.
It does, but the thinking is, in a noisy room, people without hearing loss naturally tend to speak louder. The person with otosclerosis has a healthy inner ear, cochlea. It's just the sound isn't getting there well. So when everyone else raises their voice to overcome the background noise, it helps overcome the conductive block for the otosclerosis patient.
Wow, that's a neat diagnostic clue.
Isn't it? So SNHL usually worse than noise. This specific conductive loss sometimes paradoxically better.
All right, let's shift gears now to acute infections, the stuff that brings people in with sudden pain. Starting with the ear, let's compare the two big ones. Acute otitis media, AOM, and otitis externa. So AOM, middle ear infection. What's the absolute must-see finding on exam?
For AOM, the key is what the eardrum, the tympanic membrane, or TM, looks like. It's not just red. It has to be bulging outwards because of the pressure from infected fluid behind it.
Okay, bulging.
And it'll look opaque, not translucent, often quite red. And critically, if you use a pneumatic otoscope to puff air gently against it, it won't move. It's immobile.
Yeah.
That combination, bulging, opaque, immobile TM, plus symptoms like fever and ear pain, that's AOM.
We need to be super clear differentiating that from otitis media with effusion, or OME.
Yes, crucial difference. OME just means there's fluid behind the eardrum, but it's not acutely infected.
So the TM might look different.
It might look dull, maybe retracted slightly. You might see air fluid levels or bubbles behind it, and mobility will likely be reduced. But crucially, there's no acute bulging, no intense redness, and the patient usually doesn't have fever or severe pain. They might just notice muffled hearing.
And the management is different.
Completely. OME often resolves on its own. We usually watch and wait. AOM, on the other hand, is typically a bacterial infection. Common culprits are strep pneumonia, H. flu, M. catarrhalis. So that usually requires antibiotics, typically high-dose amoxicillin, as first-line treatment.
Okay, so AOM is infection behind the drum. What about otitis externa, swimmer's ear? Where's that infection?
That's an infection of the skin, lining the external auditory canal, the tube leading from the outside world to the eardrum. The middle ear is fine.
So the eardrum itself should look okay.
Usually, yeah. And TM mobility should be normal because there's no fluid behind it. The hallmark of otitis externa is intense pain, but specifically pain triggered by manipulating the outer ear.
How so?
The absolute classic sign is exquisite pain when you gently pull on the auricle, the outer ear, or push on the tragus, that little bump of cartilage in front of the ear canal.
Why is that so painful?
Because the infection causes the skin and underlying tissue inside that narrow bony canal to become incredibly swollen and inflamed. The skin is stuck right down to the cartilage and bone, so any movement, any pressure stretches that inflamed tissue and causes severe pain. Sometimes just chewing hurts because it moves the ear canal slightly.
Makes sense. And the cause is often water exposure.
Very often, yeah. Water washes away the protective earwax, changes the pH, and lets bacteria, most commonly Pseudomonas aeruginosa, set up shop. Treatment is different too because the infection is outside the eardrum. You use topical antibiotic drops, usually something like a fluoroquinolone, that get directly to the source.
Okay, so those are the common acute infections, but they can sometimes lead to much more serious complications. Let's talk about acute mastoiditis first. This is a complication of AOM, right?
That's right. It happens when that middle ear infection isn't fully treated, or the bacteria are particularly aggressive, and the infection spreads backwards from the middle ear cavity into the mastoid air cells.
Those are the honeycomb-like bone spaces behind the ear.
Exactly. So it becomes an infection of the bone, essentially an osteitis of the mastoid part of the temporal bone.
How does that present? What are the signs that AOM has progressed to mastoiditis?
Well, you'll likely still have the signs of AOM, maybe persistent fever and ear pain, despite antibiotics. But the specific signs pointing to mastoid involvement are tenderness, redness, and swelling over the mastoid bone itself, behind the ear.
Okay, swelling behind the ear.
But the real giveaway, the classic visual clue, is displacement of the auricle. The whole outer ear gets pushed forwards, downwards, and outwards, away from the skull.
Why does it get pushed like that?
Because the pus and inflammation building up inside the mastoid bone literally pushes the ear out of its normal position. Seeing that displaced ear is a huge red flag that the infection is no longer confined to the middle ear space.
And management. This sounds like it needs more than just oral antibiotics.
Oh, yeah. This requires hospitalization, IV antibiotics to get high concentrations to the bone, and often surgical drainage, either putting a tube in the eardrum, tympanostomy, to drain the middle ear, or sometimes needing a mastoidectomy to surgically clean out the infected bone cells.
Okay, so that's infection spreading inwards to the bone. What about necrotizing otitis externa, sometimes called malignant otitis externa? That sounds even worse.
It is. This is a complication of otitis externa, the swimmer's ear infection, but it's like otitis externa on steroids, and it spreads outwards and downwards, invading the surrounding tissues and bone at the base of the skull. It's a true emergency.
Who gets this? Is it common?
Not common, thankfully, but devastating when it happens. The patient profile is absolutely key here. You need to think about this in elderly patients, anyone immunocompromised, but especially patients with diabetes. Poorly controlled diabetes is a major risk factor.
Why diabetics?
The combination of impaired immunity, poor microvascular circulation, and often higher glucose levels creates a perfect storm for Pseudomonas, the usual culprit in otitis externa, to become really invasive.
So what does the patient complain of? Is it just worse ear pain?
It's usually severe, deep, relentless ear pain, often described as worse at night, and persistent, foul-smelling, purulent discharge from the ear canal. But the pathognomonic finding, the thing you must look for on exam,
Yes.
is granulation tissue in the external auditory canal, usually seen on the floor of the canal at the junction between the cartilage and bony parts. This isn't just swelling, it's abnormal, fleshy, reddish tissue growing there.
What does that granulation tissue signify?
It represents the body's ineffective attempt to heal over an area where the infection is actively invading and destroying the underlying cartilage and bone. Seeing granulation tissue in the ear canal of a diabetic or immunocompromised patient with severe ear pain is essentially diagnostic of necrotizing otitis externa until proven otherwise.
Wow. And because it's invading bone like an osteomyelitis of the skull base, the treatment must be intense.
Extremely intense. This requires admission, aggressive IV antibiotics, specifically targeting Pseudomonas ciprofloxacin, is often the go-to. And not just for a few days. We're talking a long course, often 6 to 8 weeks of IV therapy, sometimes followed by oral antibiotics. You need imaging like CT or MRI, maybe even bone scans, to assess the extent of bone involvement and monitor response to treatment. It's a long haul.
Okay, that progression from a simple canal infection to skull base osteomyelitis really underscores the potential severity here. Let's transition now to infections involving the throat and airway, where things can go bad very, very quickly.
Absolutely. Airway is always priority one in these situations.
Let's start with the most common deep neck space infection, the peritonsillar abscess, or PTA, also known as quinsy. Where exactly is this abscess?
It's a collection of pus that forms in the space between the tonsil itself and the pharyngeal muscles surrounding it. It usually happens as a complication of tonsillitis that wasn't treated effectively or fully resolved.
And it has a pretty classic set of symptoms, right? The sources mention a triad.
Yes, a very recognizable triad. First, the patient has a severe sore throat, usually much worse on one side. Second, their voice changes. It becomes muffled, thick, like they're trying to talk with a mouthful of food, often called a hot potato voice.
Okay, sore throat, hot potato voice. What's the third part?
Trismus. That's difficulty or pain when trying to open the mouth.
Why can't they open their mouth?
Because the inflammation and swelling from the abscess irritate the nearby pterygoid muscles, which help control jaw movement, causing them to go into spasm. The inability to open the mouth wide is a huge clue for PTA. Patients also often look quite ill, maybe drooling because swallowing hurts so much. Odynophagia.
That trismus must make it hard to examine them properly.
You can, yeah. But if you can get a look inside the throat, there are key signs. You'll typically see swelling and bulging of the soft palate on the affected side, usually just above and behind the tonsil.
A unilateral bulge.
Exactly. And because that bulge is pushing things around, the uvula, the little thing hanging down in the middle, will be deviated away from the side of the abscess.
Ah, push to the opposite side.
Right. That combination, severe unilateral throat pain, hot potato voice, trismus, and contralateral uvular deviation is pretty much diagnostic.
And the management. You can't just give antibiotics for a collection of pus, right?
Correct. The abscess needs to be drained. That's the definitive treatment, usually done either by needle aspiration, sticking a needle in to draw out the pus, or by making a small incision and draining it. Plus, you give IV antibiotics that cover the likely culprits, which include group A strep, but also lots of oral anaerobes. Something like clindamycin or ampicillin sulbactam works well. Prompt drainage is key to relieve pain and prevent the infection from spreading deeper into the neck.
Okay, so PTA needs urgent drainage. But if we're talking true, immediate, life-threatening airway emergency, we have to discuss epiglottitis.
Absolutely. This is inflammation and swelling of the epiglottis and the surrounding supraglottic structures, the tissues above the vocal cords. And it can happen incredibly fast, potentially closing off the airway completely.
This used to be more common in kids, caused by Hib.
Yes. Historically, Haemophilus influenzae type B was the main cause in children. But widespread Hib vaccination has dramatically reduced that. So now we see it more in unvaccinated kids or sometimes in adults caused by other bacteria like strep species. But regardless of the cause, the presentation is alarming.
The sources mention the classic 3 Ds. What are those?
Right. The 3 Ds are a good way to remember it. Dysphagia, they suddenly find it incredibly painful or difficult to swallow anything, even saliva, drooling because they can't swallow their own secretions. And distress, significant respiratory distress, they're struggling to breathe. Some sources might say dysphonia instead of distress, meaning a muffled voice, similar to PTA, but often more severe distress overall.
And there's a characteristic posture they adopt.
Yes, the tripod position, or sometimes called the sniffing position. They'll often be sitting upright, leaning forward, neck slightly extended, mouth open, sometimes bracing themselves with their hands. They're instinctively trying to maximize whatever tiny airway opening they still have left.
Okay, so you see a patient, especially a child, looking toxic, high fever, drooling, sitting in that tripod position. What is the absolute #1 rule?
Do not disturb the airway unnecessarily and secure the airway first.
Yeah.
Meaning, do not try to examine their throat with a tongue depressor or anything else. Don't make them lie down. Don't upset them. Any manipulation could trigger complete laryngospasm and total airway obstruction.
So diagnosis comes later.
Airway management comes first. The safest place to manage this is in the operating room, with anesthesia and surgery personnel ready. The goal is controlled intubation. If that fails, they need to be prepared for an emergency surgical airway, like a cricothyrotomy or tracheostomy. Only after the airway is secure should you worry about confirming the diagnosis or starting antibiotics.
If, hypothetically, the patient was stable enough for an X-ray, what might you see?
On a lateral neck X-ray, if it's safe to get one, you might see the classic thumb sign. The swollen edematous epiglottis looks like a thumbprint indenting the airway column. But again, imaging should never delay securing the airway if the patient is in distress.
Okay, airway first. Absolutely critical for epiglottitis. Let's talk about one more deep neck infection, the retropharyngeal abscess, or RPA. Where is this one located?
This is an abscess in the potential space behind the pharynx, between the back wall of the throat and the provertebral fascia covering the spine. It often contains lymph nodes that drain the nose, sinuses, and pharynx.
How does this usually start?
In young children, it's often from suppurative lymph nodes following an upper respiratory infection. In older kids or adults, it's more commonly due to direct spread from another infection, or quite often from penetrating trauma.
Trauma
Like swallowing a sharp object, like a fishbone that punctures the back of the throat. Or sometimes after medical instrumentation, like a difficult intubation or endoscopy.
And the symptoms, how would this look different from, say, PTA?
They'll have similar symptoms like fever, severe sore throat, difficulty swallowing, adenophagia, maybe muffled voice. But the key distinguishing feature for RPA is often significant neck stiffness or pain, particularly with extending the neck, hyperextension.
Why the neck stiffness?
Because the abscess is sitting right in front of the cervical spine, irritating those deep neck muscles and fascia. Patients might hold their neck rigidly, refuse to turn their head. It can sometimes even mimic meningitis because of the neck signs. They might also have noisy breathing or stridor if the abscess is large enough to compress the airway.
Okay, so neck stiffness is a big clue. Now, the sources really emphasize the potential for this to spread catastrophically. Talk about the danger space.
Ah, yes, the danger space. This is where neck anatomy gets terrifyingly relevant. The retropharyngeal space, where the RPA initially forms, is separated from the space directly in front of the vertebrae by a thin fascial layer called the alar fascia.
Okay.
If the infection breaks through that alar fascia, it enters the true danger space, also called the prevertebral space, confusingly, but conceptually it's the danger zone. And this space is unique because it's a continuous fascial plane that runs directly from the base of the skull all the way down into the posterior mediastinum in the chest.
So it's like an express lane to the chest.
Exactly. There are no barriers. Once infection gets into the danger space, it can track downwards rapidly, leading to the most feared complication, acute necrotizing mediastinitis.
Infection and inflammation spreading around the heart and great vessels.
Yes. It's a fulminant, often fatal condition requiring aggressive surgical drainage of the chest and broad-spectrum antibiotics. Mortality rates are very high.
So that neck stiffness in RPA isn't just about local pain.
It's potentially a sign that the infection is deep and could be threatening to spread downwards. That's why suspected RPA needs urgent imaging, usually a CT scan of the neck with contrast, to confirm the abscess, see how big it is, and crucially, to look for any signs of extension into the danger space or early mediastinal involvement.
That's a stark reminder of how interconnected these spaces are. Let's shift now from acute emergencies to some chronic conditions, particularly those in the mouth that might signal brighter issues or risks, starting with oral leukoplakia.
Right. Leukoplakia is important because it's defined specifically as a premalignant lesion, meaning it has the potential to turn into cancer later on.
And the key feature in its definition helps distinguish it.
Yes. The definition is a white patch or plaque on the oral mucosa, the lining of the mouth that cannot be scraped off.
Okay, that's critical. If it can be scraped off.
Then you're probably dealing with something like oral candidiasis or thrush, which is a fungal infection. That usually scrapes off, leaving a red, sometimes bleeding base underneath. Leukoplakia is different. The whiteness is due to thickening of the epithelial layer itself, sometimes with abnormal cell changes. Dysplasia, it's part of the tissue.
So, non-scrapable white patch leukoplakia potential risk. What drives the development of these lesions?
The biggest risk factors, by far, are tobacco use, smoking, chewing tobacco, and chronic heavy alcohol consumption.
And the sources mentioned they have a combined effect.
Yes, a powerful synergistic effect. Using both tobacco and alcohol together multiplies the risk of developing oral squamous cell carcinoma, SCC, much more than either one alone. While most leukoplakias don't turn into cancer, a significant percentage do, especially certain types, so we have to take them seriously.
How do you decide what to do? Just watch it, biopsy it.
It often depends on the appearance and the patient's risk factors. Small, thin, smooth, homogeneous white patches might be monitored closely, especially if the patient quits tobacco and reduces alcohol. But any lesion that looks suspicious, like if it's thick, has a rough or pebbly surface, feels hard, indurated to the touch, has red areas mixed in, erythroplakia, or is ulcerated by, those need to be biopsied promptly. The biopsy tells you if there's dysplasia and how severe it is, or if invasive cancer is already present. Basically, see a non-scrapable white patch, especially in a smoker or a heavy drinker, think risk, consider biopsy.
Okay, good rule. Finally, let's look at a really interesting systemic condition that ties together the nose, the lungs, and a specific medication reaction. Aspirin exacerbated respiratory disease, or AERD.
Yes, this is a fascinating one. It's important to know it's not a true IgE-mediated allergy like a peanut allergy. It's considered more of a chronic inflammatory condition, a pseudo-allergy.
And it presents with a specific cluster of problems, right? Triad.
It's exactly. AERD is defined by this triad, typically developing in adulthood. Number 1, adult onset asthma, often moderate to severe. Number 2, chronic rhinosinusitis with significant, often recurrent, nasal polyposis. These patients frequently have terrible nasal congestion and lose their sense of smell.
Okay, asthma and nasal polyps.
Yeah.
What's the third defining feature?
The third is the characteristic respiratory reaction after taking aspirin or other NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen or naproxen.
What kind of reaction?
Within minutes to hours after ingestion, they develop acute bronchospasm, wheezing, shortness of breath, and/or significant nasal congestion, runny nose, sometimes even facial flushing or gastrointestinal upset. It's a very specific trigger.
So taking a common pain reliever causes an asthma attack and plugs up their nose. What's the underlying biology there? Why does blocking KOX1 with aspirin cause this?
It's all about biochemical pathways. Aspirin and NSAIDs work by inhibiting the cyclooxygenase enzymes, particularly KOX1. This enzyme normally helps produce prostaglandins, some of which are actually protective in the airways. In people with AUE, when you block that COX pathway, the precursor molecules, like arachidonic acid, get shunted down an alternative pathway, the lipoxygenase pathway.
And that leads to?
Massive overproduction of inflammatory molecules called lutetrienes.
Ah, leukotrienes. We know those are bad news for airways.
Exactly. They are incredibly potent mediators of inflammation. They cause bronchoconstriction, tightening the airways, increase mucus production, increase vascular permeability, leading to swelling, and attract inflammatory cells. This flood of leukotrienes is what drives the acute reaction to NSAIDs and likely contributes to the underlying chronic asthma and nasal polyposis as well.
So the chronic state involves polyps, asthma, and then aspirin makes it acutely worse by flooding the system with leukotrienes.
That's the model, yes. These patients often have really stubborn nasal polyps that keep coming back even after surgery, and their asthma can be difficult to control. Many also report complete loss of smell, anosmia, because the polyps physically block the olfactory receptors.
So how do you manage A or D? Obviously, avoid aspirin and NSAIDs.
That's step one, absolutely critical avoidance. Then you manage the underlying asthma and chronic rhinosinusitis, often needing inhaled corticosteroids, sometimes oral steroids for flares. And given the role of leukotrienes,
Medications targeting them would make sense?
yes, leukotriene-modifying agents like montelukast or zafirlukosine can be particularly helpful in AERD, sometimes more so than in regular asthma. For some patients, especially those with severe polyps, biologic medications targeting specific inflammatory pathways might be needed.
What if someone with AERD needs to take aspirin, say, for heart disease?
That's a great question. For patients who have a clear cardiovascular indication for aspirin, there's a procedure called aspirin desensitization. It's done carefully, usually in a hospital setting, by giving gradually increasing doses of aspirin over hours or days. This somehow reprograms the body's response, allowing the patient to tolerate daily aspirin therapy long-term, which can actually also help control their polyps and asthma symptoms sometimes. #CAGOutro. Well, we've certainly covered a lot of ground today, from jaw pain referring to the ear to chronic growths, acute infections, and these complex airway emergencies. I think the big theme really is how connected everything is in the head and neck.
It really is, and how understanding the function and the triggers is so key. Like you said, TMD pain worsens with movement, but the silolithiasis worsens with eating. That's a crucial distinction.
Exactly. Or recognizing that chronic painless ear discharge isn't just a nuisance, it could be a cholesteatoma, slowly eroding bone.
Right. Or seeing that granulation tissue in a diabetic patient's ear canal means necrotizing otitis externa and weeks of 5E antibiotics. And then the airway emergencies. The muffled voice and trismus of PTA needing drainage versus the drooling and tripod position of epiglottitis needing immediate airway control before anything else.
That speed, particularly with airway issues and deep neck infections, is probably the most critical takeaway. Thinking back to the retropharyngeal abscess.
Again, the danger space, yeah.
That's quite something, isn't it? That an infection starting behind the throat has this anatomical pathway, this fascial plane, that offers a direct, uninterrupted route down into the chest, potentially leading to catastrophic mediastinitis within hours or days.
It really drives home why something like neck stiffness with a severe sore throat can't just be dismissed. It could be signaling a risk far beyond the neck itself, requiring immediate advanced imaging.
Absolutely. The body's design is efficient, sometimes terrifyingly so when infection finds those pathways. It might be worthwhile for listeners, actually, to maybe look up some diagrams of those deep fascial planes of the neck. It really helps visualize how quickly things can spread if not caught early.
That's a great suggestion, a really insightful deep dive today. Thanks for walking us through all that. And thanks to all of you for joining us. Until next time, stay curious.